Hello, today I will talk about acute pancreatitis. This is a relatively common serious cause of abdominal pain in the middle-aged and elderly. Most are due to gallstones or alcohol. Sometimes are idiopathic. Other causes include hypothermia, trauma, infections such as glandular fever, mumps, Coxsackie, and infectious hepatitis. Also include hyperlipidemia, hyperparathyroidism, and drugs like steroids, azathioprine, thiazides, and statins. There are some other causes such as pancreatic cancer, post-ERCP, and scorpion stings. Typically, the complaint is of severe constant epigastric pain radiating to the center of the back, possibly relieved by leaning forward, with associated nausea and vomiting. The patient may be distressed, sweating, and mildly pyrexial. Look for evidence of shock. There may be a need for urgent resuscitation. Abdominal tenderness is likely to be maximal in the epigastrium, plus/minus sign-guarding. The oft-quoted, but uncommon, bluish discoloration in the loins, which called gray Turner's sign, only develops after several days. Serum amylase is likely to be grossly more than 4 times upper limit of normal range. Note that mild increased amylase may occur in a wide range of other acute abdominal conditions. Serum lipase may be measured, instead of amylase. CBC may reveal increased white blood cells. Also, check coagulation profile, oxygen saturation, ABG including lactate, and glucose level, because hypocalcemia is relatively common. Steps of treatment include, provide O2, obtain IV access, and resuscitate with IV crystalloid fluids as necessary. Give IV analgesia, for example morphine. Give an antiemetic, for example cyclizine 50 mg or metoclopramide 10 mg slow IV. Insert an esophageal tube. Insert a urinary catheter and monitor urine output. Consider early involvement of the critical care team, and possible insertion of a central venous line to monitor the CVP, and guide IV fluid therapy in the seriously ill, particularly the elderly. Then contact the appropriate specialist and refer to ICU.
Acute pancreatitis has significant mortality. Early complications include DIC, hypocalcemia, and acute respiratory distress syndrome. Later, pancreatic abscess or pseudocyst may occur. The risk of death may be predicted according to the number of prognostic indicators present in Glasgow's scoring system. 3 or more of the following 8 findings on admission, and subsequent repeat tests over 48 hours constitute severe disease. 1. Partial pressure of O2 less than 7.9. 2. Age greater than 55 years. 3. Neutrophilia if white blood cells greater than 15 times 109 per liter. 4. Corrected calcium less than 2 millimol per liter. 5. Raised blood urea greater than 16 millimol per liter. 6. Elevated enzymes, serum LDH greater than 600, AST greater than 100 unit per liter. 7. Albumin less than 32 grams per liter. 8. Elevated sugar, fasting glucose greater than 10 millimol per liter.
Now I will talking about chronic pancreatitis. The term chronic pancreatitis implies permanent pancreatic damage. The condition most often results from alcohol excess. Some patients with chronic pancreatitis present frequently to the ED requesting analgesia. This can pose a difficult problem for the doctor who has not treated them previously. Patients with chronic pancreatitis can experience severe episodes of acute pancreatitis. For patients with alcohol-related chronic pancreatitis, consider the need for IV thiamine, for example Prebornex, and diazepam or chlordiazepoxide. Many patients with chronic pancreatitis can be successfully managed on an outpatient basis without admission to hospital. Refer for admission patients with dehydration, shock, severe illness, uncontrolled pain or vomiting. Thank you for watching. Goodbye.